Very good morning to one and all present here, and I thank the scientific committee for giving me this opportunity. So my topic today is why do patients present late in glaucoma and how to avoid the glaucoma blindness in our country. I don't have any financial disclosure to make. So when we see the magnitude of the problem, we can understand how big that issue is about glaucoma blindness. Among Indians, glaucoma prevalence is between 2.7 and 4.3 in adults aged 40 years and above, and it is causing blindness in 1.2 million people and accounts for 5.5% of the total blindness. That is a huge burden of glaucoma, and almost 10 to 33% of the people with glaucoma had advanced disease and were visually impaired at the first diagnosis. So we all know that the late the patient present with glaucoma, the more chances of blindness for his or her life. So why do patients present late in glaucoma? We have to analyze it. There can be delayed diagnosis, there can be inadequate or improper treatment, and there can be non-compliance to the treatment. So in case of delayed diagnosis, why the diagnosis is delayed? Because glaucoma is an asymptomatic disease, and all these things can occur which will cause the delayed diagnosis. There is lack of effective screening strategy because glaucoma screening in the population community-based screening is not feasible, and opportunistic screening is the only method when we can catch some glaucoma patients, and we have to screen the first degree relative of glaucoma patient, and we can take the help of optometrists and train them properly so that they can detect glaucoma at an early stage, and AI-based algorithms and tele-ophthalmologists are coming nowadays, and they will help definitely us to screen the glaucoma patients. So another cause of delayed diagnosis is inadequate glaucoma awareness. Glaucoma awareness is not very much in our general population, so it should be an ongoing process, not as a special event like a glaucoma prevention week or awareness week like that. It should be a continuous process. We can take the help of information brochures, QR coded linked resources, mass media channels, and running messages on the screens when the patient is waiting for his next visit time. So those should be utilized to create the awareness. And another cause of delay is at the patient's level, because it is asymptomatic, and our population is not very keen of going for regular visit, so it gets unnoticed most of the time. And usually at the age of 40, they go to the presbyopic correction and they get a glass and come back. But many of the optical shops do not have any optometrist assistance, so it gets missed. The vision is corrected to 6/6 and 6, but it is missed because of the lack of comprehensive ophthalmic examination. And availability and affordability are definitely issues which is a concern for the delayed diagnosis presentation. And sometimes the people think that it is a deterioration of the vision is a normal aging process. They think that we have got cataract, and once it gets matured, we will operate. But when they think it is matured and the vision is totally lost, it is due to glaucoma, and nothing can be done about that. So another thing is that misdiagnosis. Even if the patient visits an ophthalmologist or optometrist, it can be very well missed, because we rely on a high amount on the IOP measurement. IOP 21 more is glaucoma, less is not glaucoma, but that is not the case, and it has got its own limitation. And threshold for the IOP induced damage is not same for all the patients. Sometimes we can see that the patient has visited an optometrist, but his optic disc has been never looked at. So that is a condition, and even if it is looked at, so many things are missed if we do not look at the subtle points. That is underestimating the vertical curve disc ratio, missing the RNFL layer defect, and missing the disc hemorrhage and neuroretinal rim loss. So in a GONE project, it has been found that almost 1/5 of the examinations, they miss in the trainees and the general ophthalmologists, they miss the early glaucomatous changes. So these are the things we have to carefully look at. And the misdiagnosis, and another very much blunder is missing an angle closure component, because angle closure is very much predominant in our part of the country, our part of the world, like the Asian countries. And one should have a gonioscopy if we suspect. Otherwise, the angle closure glaucoma will be treated as an open angle glaucoma, whereas only a simple PI will help. But the patient lands up in absolute glaucoma because the angle closure has been misdiagnosed as glaucoma or other refractive error or some other causes. So missing an angle closure component should not be there in our condition. So these are the things which can cause glaucoma, like pseudo-exfoliation, which is very common, traumatic glaucoma, there is steroid-induced glaucoma. All these things should be looked at. And if the patient IOP is not controlled with this routine test, and even after the patients have reached the target pressure, then we have to think about the other things also. And there is inadequate or improper treatment. Why this occurs? Because sometimes the severity of the damage at baseline is underestimated. If our target pressure is dependent on the baseline damage, if we underestimate the severity, then what happens? It set is a higher target pressure is set, and that leads to less aggressive treatment and ultimately disease progression. So missing IOP is another thing which usually occurs if we only record the pressure once in the day, and though it is difficult, then at least it should be done in cases where we expect that the pressure should be lower, but it is not getting sufficiently lowered. So non-compliance to treatment is also very much in case, because glaucoma is an asymptomatic case, and when we start treatment for glaucoma, the only thing patient experiences is the side effect of the drug, but not the benefit, because we have to convince him that there is no chance of any benefit, but only we have to halt the disease process at that stage which he has presented to us. That should be imprinted in the patient mind. Imagine that suddenly the vision will improve and everything, but that should be clearly conveyed to the patient that we only try to arrest the disease at that stage. So to conclude, we can control the burden of the glaucoma by raising the awareness about glaucoma, increasing the early detection, enhancing diagnosis and find out the cause of condition and treat them, and ensuring availability and affordability of glaucoma diagnostic and therapeutic. That way we can combat the glaucoma blindness. Thank you.
Thank you, Dr. Sumita, for nice talk. Our next speaker is Dr.
So, ma'am, there's also one more thing that we realize, that there can be misdiagnosis, because especially in the glaucomas that are not asymptomatic and those who have headaches, usually the patients never come to an ophthalmologist. They'll go to the medicine person or the neurologist, and they don't have a SOP or protocol that every headache should ideally be seen by an ophthalmologist. That is what we are trying to propose in the park, because every headache is not referred to an ophthalmologist, especially by the DM. The people who have already done DM, they will say that, find it below the dignity to refer to an MS or MD person. And then we realize that those patients have been just treated with painkillers. Yeah, but now more and more So we did a small study for headache patients, and we found that most of the headache patients were referred to medicine and neurology. So that's the reason. Also, ma'am, there's one more thing that we need to stress on, why they are missed by the ophthalmologist, because they should see them at different times in the day also. That's why the diurnal variation. So that also needs to be. Thank you.